All right. All right. Okay, so today we'll continue on with our very basic drug talks. So today we're going to talk about class 2 agents, which are beta blockers. So the mechanism of effect of a beta blocker is competitive inhibition of the catecholamine binding cardiac receptors. They reduce normal and abnormal automaticity, and they slow AV nodal conduction. They can also have direct membrane effects, prolonging the action potential and the effective refractory period. And they can and usually do increase the threshold for ventricular fibrillation, which is obviously positive. They are particularly effective clinically in catecholamine-sensitive tachycardias from either abnormal automaticity or so-called triggered automaticity. But as you've seen, we use it quite frequently for reentrant arrhythmias, particularly those that use the AV node, such as orthodromic reentrant tachycardia or AVNRT. And in those circumstances, the most common mechanism for efficacy of beta blockers is thought to be reduction in premature beats, either in the atrium or the ventricle, as well as AV nodal effects as well. So it's making a noise, but it's okay. Okay. There are different types of beta blockers. First, let's go through the so-called non-selective beta blockers, and those are propranolol and nadolol. And they're non-selective, or called non-selective, because they affect both the beta-1 or the cardiac receptors, as well as the beta-2 or the bronchial and blood vessel receptors. And because of that, because particularly of the beta-2 action, they can aggravate reactive airway disease. So you have to consider that fact when you're prescribing them. And they may also worsen ventricular function by their effect on beta-1 action. And nadolol also is non-selective, affecting beta-1 and beta-2. But the major difference between it and propranolol is the half-life. Nadolol has a longer half-life in general and has more penetration to the brain, passes the so-called blood-brain barrier better. Both agents are the preferred agents for the treatment of long QT syndrome, as well as CPVT, or catecholaminergic polymorphic VT. Now, other beta blockers have been demonstrated to be effective in very small studies, but as a general rule, if you were to look at the literature on long QT syndrome in particular, it's very clear that the agents that have been studied by far the most in the largest series have been propranolol and nadolol. And these are the two agents that have been definitively demonstrated to be effective in reducing the risk for torsade and sudden death. And so for that reason, it would be unusual not to use one of those two agents for the treatment of long QT syndrome, as well as CPVT. That's why you see that the vast majority of our long QT patients are on one of these two agents. Again, there are small studies that have shown efficacy with other beta blockers, but they're generally very small, and there are often conflicting reports of their efficacy depending on the study. So I would say, as a general rule, if at all possible, if treating long QT syndrome or CPVT, you want to really stick tight to propranolol or nadolol. There are other beta blockers that are more cardioselective, meaning that they're more beta-1 and not beta-2 acting. And these include atenolol and metoprolol, which are two of our more common agents that we use mostly for people with relatively minor or non-life-threatening arrhythmias, such as SVT. And then esmolol is cardioselective. And esmolol, as you know, is an IV agent, probably is the only one of all of these agents that should be used IV. I would not use propranolol IV. I've seen many, you can have dosing errors that can be very life-threatening. It has a very short half-life, has rapid onset and offset for that reason, and you can titrate the dose up. You can see the effect within minutes of starting this agent. It's generally a sort of emergency beta blocker, so it's good for patients who are in torsade. It's generally good for arrhythmias where there no enteral agents are possible, certain arrhythmias, and it can sometimes be used by some to control SVT acutely. You probably have noticed that both I and Barry Love do not generally use esmolol very much because I have generally not been impressed that it's a great antiarrhythmic agent, but there are many electrophysiologists and cardiologists who think it's an excellent agent and use it all the time. Perhaps I'm just not using it properly. So that's our review this morning of beta blockers. But I think the one thing I want to mention is all beta blockers may affect beta-2 receptors despite the nomenclature cardioselective. So although you would sort of choose these agents in somebody who had, for example, asthma, you always have to keep in mind that there may in fact be some beta-2 receptor agonism from these or blocking from these agents. And so they are cardioselective, but only to a degree. All right, let's go on to some cases. So this is a text message that I received about a patient who had an atrial pacemaker and sinus node disease. And this is what the doctor wrote. I send her EKG for you to look at. I think she is pacing at 65, but her pacemaker is set at 50. So am I wrong? And is she in sinus rhythm? She had one conducted beat for sure with a paced beat afterward at 60. I told you were the expert and I don't know much. So this is the tracing that the doctor was referring to. And why don't I ask Grace Kung what she thinks she's looking at here.
Hi, Dr. Pass. So looking at that very bottom line with the tracing, I do see that there is a P before each QRS, and the PR interval seems steady, and the rate looks like 51 to 75, probably around 60, as you mentioned, and it looks pretty regular to me. Yeah, looks pretty regular, except for the very first R2R that's seen in the beginning of the EKG.
Okay.
And in the very first R2R that's seen, the P wave looks, the second one, I don't think that we're able to see very well, but from the very first one and all the rest of them, they look the same. It's hard for me to tell. Let me think about it a little bit.
Okay. We're happy to give you time to think a little bit.
Oh, let's look at the P wave axis, of course. I'm not really, it doesn't look like it's sinus. It's definitely down in AVF. In 1 and 2, I can't really tell, but I would not say that it is sinus rhythm.
Mm-hmm. Okay. So you're saying a non-sinus atrial rhythm.
Mm-hmm.
Am I correctly summarizing your thoughts on this?
Yes.
Okay. Well, I guess the first question I would ask is if somebody is apaced at 60, could that be consistent with this tracing?
I think so. Yes.
Mm-hmm. How so?
There's looks pretty regular in interval. There's a P wave that's a paced, could be a paced, and we're not seeing the pacing spike for whatever the reason.
All right. So why? So I think when you look at this tracing, if you look carefully, particularly in V1, you can see a tiny little pacing spike.
Oh,
Small. So I'll remind you that when we pace the atrium and the heart rate, I think the person who wrote me is correct that this heart rate is not exactly 60, right? It's a little faster than 60. It's like 65, right? So she is really asking me, is the patient paced? And if the patient is paced and has a lower rate limit set at 60, how is it that the patient is above 60?
oh,
Okay. And so the first thing to say is when somebody is paced, particularly when they're using a bipolar pacemaker, oftentimes you will not see the pacing spike on the ECG, or it may be very small. You can see examples here. Remember that in a bipolar pacing lead, you have two electrodes on the very tip of the pacing lead, and the electrons are going from the one pole to the other at a very small distance, sometimes as small as 2 millimeters. And that is often going to create virtually no artifact on the surface ECG. Now, sometimes it will make a larger artifact, sometimes less. When patients have unipolar pacemakers, remember that all pacing is bipolar. There always has to be a cathode and an anode, and the electrons always have to go from one to the other. And when a patient has what we refer to as a unipolar pacing lead, all that means is that there is one electrode at the tip of the lead, and the pacemaker itself is the other electrode, is the reference electrode, as opposed to having two electrodes at the tip of the lead. When you have but in both cases, the pacing is bipolar in that you're sending the electrons from one pole to the other. The difference is that the poles are very far apart in a unipolar because the lead only has one electrode at the end. We very rarely today use unipolar pacemaker leads, but when you do use a unipolar lead, you have a very, very large artifact on the ECG because the electrons are traveling a large distance from the tip of the lead all the way to wherever the pacemaker is located. So unipolar pacemakers often have very large artifacts on the tracing. Bipolar pacemaker can have variable ones, but in this case, they're very small, and you can understand why the cardiologist who sent me this text was a little unsure. The other question is, so this is what the patient's pacemaker program was. So the patient was programmed AAIR. So again, just to remind everybody, the first letter is the chamber that is paced. The second letter is the chamber that is sensed. The third is whether it's inhibited or triggered by activity. And the fourth is special features. And in this case, it has an R. And R stands for rate responsiveness. And what that means, again, I realize that a lot of you know this already, but we're only in August. When a pacemaker is rate responsive, pacemakers have in them ways of detecting activity or motion or increased need for heart rate. And it will, when the pacemaker senses that, it will slowly increase the heart rate accordingly. In this particular model, which is a Medtronic pacemaker, there is a piezoelectric crystal that can feel activity and motion. And as it is triggered by the motion, it will slowly raise the heart rate from 60 to whatever upper sensor rate. This is the sensor, meaning the piezoelectric crystal, of 130. And so if a patient is walking down the hallway to get their EKG after walking from the garage to come to clinic, the pacemaker ought to be able to sense some activity and slowly increase it from the lower rate to whatever rate it thinks is appropriate. Now, I'll tell you, there are many studies that have been that have shown that as a general rule, the piezoelectric crystal in most patients' pacemakers are very insensitive. And most patients live at rates fairly close to their lower rate, particularly when they have sinus node dysfunction. And you can make the piezoelectric crystal more sensitive in a Medtronic pacemaker. Actually, in all pacemakers, you can make the sensing of activity a little greater. But in my personal experience, when you do that in someone who is used to a certain level of sensor sensitivity, they can sometimes complain of feeling as if their heart is racing all the time. And interestingly, even though you or I with a normal sinus node may not feel good with heart rates that are hovering around 60 or 65 most of the time, patients who are used to that do not feel comfortable with slightly more normal, higher heart rates with activity. So in this particular patient's tracing, this is AAIR pacing. This is probably a PAC, which is why there's an irregularity here in this beat. But it is not unreasonable for the patient to be paced a little bit above rate of 60. The other interesting feature that this particular pacemaker has is something, we'll talk about it later in the year, something called MVP pacing, or minimal ventricular pacing program. So basically, what this is intended for are patients who have conduction most of the time, but who occasionally will block a beat. So for example, somebody who has second-degree heart block, whether Mobitz 1 or Mobitz 2. And so what the pacemaker does is it has an algorithm where it's always looking to see if there's a QRS after every atrial depolarization. In this particular case, of course, the pacemaker has to be a dual chamber pacemaker, has to have a lead in the A and the V. In this patient, that's how the pacemaker is set up, but the patient is programmed AAI. But if the patient were to have more than one non-conductive P wave, the device will automatically switch to a DDD modality temporarily, so as a safety feature to make sure that there's always a ventricular contraction after every atrial contraction. And then I have to look at the algorithm, but I believe that something like after 30 seconds, it will start looking to see if there is conduction. And if there is, it will revert back to AAI. And so this is a very nice safety feature. And the theory behind it is that ventricular pacing is generally not good for you unless it's a specific kind of V pacing. It is associated with less ventricular function. Of course, it uses the battery of the pacemaker more. So there's lots of good reasons that you would rather not V pace if you did not have to. And this is a nice feature that is now available in all Medtronic dual chamber pacemakers. In this patient, you could argue it's overkill because, to my knowledge, this patient never did have AV conduction, but it's almost a nice safety feature to have available. So the answer to the doctor's question was that the pacemaker is working fine. Okay, this is a 16-year-old who's in the emergency room and is complaining of dizziness. So I'm going to ask Dr. Bonsall what she thinks is going on here.
Good morning, Dr. Pass. So it looks like irregular rhythm with white complex QRS.
Mm-hmm.
And as you always say, that irregular with white complex AFib with aberrant conduction.
What do you mean by aberrant conduction? I'm not sure what that means.
Rapid ventricular repolarization, basically.
Okay, now why is the ventricle depolarizing so rapidly? Could this happen through your AV node?
This is conducting through the accessory pathway. Your SVT is conducting through your accessory pathway, and that's why it's white complex.
Right. Okay. So, all right. So I agree. This is rapidly conducted atrial fibrillation in the setting of WPW. Very good. So how would you treat this, Verna?
So cardioversion.
Okay. And how many joules per kilo would you give the patient?
We will start with 0.5 per kg with 0.5 joules per kg.
Okay, but the ventricle's going very fast. You still feel confident in that choice? You might be right. I'm just trying to confuse you here. What arrhythmia are we trying to stop here?
2 joules per kg. Now that you've confused.
Okay, you have to stick to your guns, Dr. Bonsall. So what arrhythmia are you trying to terminate here?
I'm trying to terminate AFib that's being conducted to the accessory pathway.
Okay, so what's the treatment for atrial arrhythmias?
Synchronized cardioversion.
At how many joules per kilo again?
1 joule per kg.
Oh boy, you are all over the place. No, your first choice was correct. It would be a half a joule per kilo, would be an appropriate starting dose for an atrial arrhythmia. You're seeing rapid conduction, so it's, I'm trying to confuse you by saying, well, but you're worried about what's happening in the ventricle. But of course, that's all coming from the atrium, right? So you could give as little as 0.5 per kilo. I will be honest in telling you, I don't generally start at 0.5 joules per kilo. I usually start at 1 joule per kilo. But formally, the correct answer is a half a joule per kilo. Actually, about 15 years ago, Leo Lieberman and I wrote a paper in which we showed that I think as little as a third of a joule per kilo is effective most of the time, but we don't generally use that dose very often or at all. What would be the advantage of using a half a joule versus say 1 or 2 joules per kilo? Because 1 or 2 joules would not necessarily be wrong, but why would you generally want to use less if you could?
I mean, lesser energy is better because if it doesn't work, you could always go up. You have room to go up.
Okay, but all right, that's one option.
And then lesser burn.
Lesser burn, you mean like on the surface of the skin from the, but usually you only get at most, the equivalent of a suntan from the cardioversion. Not usually. Usually it's not that dangerous to the skin. We don't usually consider that as a thought when we're considering cardioversion, but okay, you're very dermatologically inclined, so yes. Any other reasons? What about the effect of cardioversion on the heart?
It restarts basically
Yes.
it resets your sinus nodes. So basically.
But does it have any direct effects on the myocardium function and stuff like that?
If you're asking, then it probably decreases it momentarily.
Yes, good surmising there. Yes, cardioversion is a negative inotrope, and it definitely can cause dysfunction. And so there's a lot of schools of thought in the world of adult cardiology. There are some studies that show that you should just to any adult give 200 joules to everybody. That's actually more likely to be effective. And the theory is, even though it is a lot more energy and therefore a myocardial depressant, maybe on balance, patients will receive fewer shocks and less energy if they just get one big shock. But in pediatrics, I would say we don't generally do that. Most of the time, I would give somebody 1 joule per kilo. Why is it synchronized? What is it synchronized? When you say synchronized cardioversion, I agree with you 100%. Why is it synchronized, and to what is it synchronized?
So the defibrillator tries to correlate with the QRS complex of the patient's patient's QRS complex, and then if it is not synchronized, we could put the cardioversion could put R on T wave, and that could lead to VFib.
Right. So that's exactly right. And so that's an important point. We are synchronizing because we do not want to put an R on a T wave, even though we are actually not treating a ventricular arrhythmia at all. If you're not careful, you will inadvertently shock the patient at the wrong time and cause VF. And actually the next tracing, the reason it was put on the internet is because it was done asynchronously and the patient ended up with VF. Now, let's say that happened. Let's say you accidentally put an R on T and you got VF. What would you then do, Perna?
Then it would be defibrillation with 2 joules per kg.
That's right. You would defibrillate with 2 joules per kilo. And that's in fact what the doctors did successfully. Now, let's say, yes, David Barris. So David, let's say we are in a developing world nation and there is a power outage and you're in the emergency department and this patient is sitting there and you cannot actually defibrillate this patient electrically, or cardiovert, I should say, this patient electrically. So what other things could you do if you did not have electricity at your disposal?
You could treat medically with procainamide or amiodarone.
Right. So that's exactly right. So you would give procainamide because, or amio, but proc would be the sort of more proper answer because proc prolongs the effective refractory period of accessory pathways. So first of all, it should slow the rapid ventricular conduction quite quickly. And it may in fact treat the AFib as well. It might terminate the atrial fibrillation. What do you make of the fact that the patient is awake and is complaining of dizziness? Does that give you comfort that the patient is okay, not?
Well, I mean, it tells me that they're hemodynamically not their blood pressure is okay for the moment because they're conscious. So I'm reassured in that sense. But given the nature of the arrhythmia, I would want to act quickly, nonetheless.
Right. Absolutely. This could degenerate into VFib very quickly. This patient is lucky that they were alive long enough to get this tracing. Now, you've cardioverted the patient. They have WPW. What are you going to tell this patient? What should the next steps be? So you're in the ER. You've just cardioverted the patient. Patient is now feeling well, wants to go home. What would you say about this patient?
Well, this patient's kind of proven themselves to be a high risk WPW, so I guess ablation is already, indicated for sure.
What about this tracing means that the patient is high risk? I agree with you, but just for those in the audience who do not
So
know.
I think, the things that we care about for WPW is, one is just regular SVT, but the thing that we're worried about the most is risk for sudden death because of this very arrhythmia, rapidly conducted AFib. So I think what we do when we go to the EP lab when someone does not have this arrhythmia yet is to kind of test them to see whether they can their accessory pathway can conduct at faster cycle lengths, and then therefore be able to go into this arrhythmia. And this patient's already proven they can. So
yes, that's right. So the general line in the sand is cycle length 250 milliseconds. If you can conduct faster than that, or at a cycle length lower than that, we would consider you to be high risk. And we see here that there's an R to R here of less of about 200 milliseconds. So this is a very dangerous form of WPW. And so, yes, one would want to ablate this patient. And generally, one would not send a patient like this home, at least in the United States, unless they were either ablated or placed on an agent that could prolong the refractory period of the pathway temporarily until such time that they could be ablated. You could put them on procainamide if they're 16 years old, or you could put them on something like flecainide as a temporizing age thing, although there's some controversy about that. So, okay. All right. This is a 2-week-old seen in the pediatrician's office for routine office visit, and the heart rate is 75. I'm telling you that because there's no lines on this patient, on this tracing, and they're sent to cardiology. So what workup should be done? Should any intervention be done? If so, what intervention? I'm going to ask Sergey Babia what he thinks about this.
Good morning.
Good morning, Sergey.
Based on this tracing, it looks like that there is complete heart block.
Mm-hmm.
And because we see that there's A's and V's are kind of not together, coming not together.
Yep.
And the RR interval is fixed. So we would work up mom first for a history of lupus.
Also,
And
other connective tissue disorders like Sjogren's can also
Sjogren's,
yeah.
yes. And then interventions wise.
Well, how would you assess the baby?
The baby. The Zeo patch or any Holter monitor for the baby. I'll do an echo.
And what are you looking for? I agree with both of those suggestions. What are you looking for on the echo first?
On the echo, I'll be looking for any kind of signs of decreased function in view of this heart block.
Yeah, you can get myocarditis from maternal lupus. Yeah, you would want to check for that. But all right, so the echo looks normal. The heart rate is slow. The patient's ventricle's a little dilated, but the function is preserved. And what are you looking at on the Holter? What are you trying to assess there?
I believe we need to we kind of need to decide whether this baby needs a pacemaker or not. And the way we can decide is probably by assessing the rate at which he lives.
Okay. So you'd want to look at the average rate. There are a number of criteria, and they just changed. And so we'll go over that in the next few weeks. But basically, the average heart rate is one of the more important factors you're looking at on a Holter in somebody who has what appears to be congenital complete heart block. And so you would want to look for what the average heart rate is. Below 50 to 55 is generally considered an indication, although I believe in the new indications, it says when the patient is awake. It should be between 70 and 70, between 50 and 55 or above. And you want to look for the presence of long pauses, of wide QRS escape beats, but most importantly, you want to look at the patient and see if the patient is symptomatic in any way, has any signs for low cardiac output, low energy, not feeding well, sweating with feeds, fainting of any sort. All of these would be worrisome signs that would be considered class 1 indications for a pacemaker. Now, you would also probably check all the normal things like thyroid functions on the infant, just to make sure that you don't have a congenital hypothyroidism, which can also cause heart block. Okay. And then this patient would need to be followed regularly if you chose not to put a pacemaker in. And usually we would follow a patient like this, maybe, this is somewhat stylistic, but I think probably maybe see the patient 3 months of age, then maybe at 6 months, and then probably annually at that point. So maybe at a year of age and then annually. And the parents always have to be made aware that if they have any symptoms of low cardiac output, which you would explain to them, or if there was ever fainting, that would be an immediate reason to call cardiology for possible intervention. Okay. This is post-op night 1 after a VSD coarc repair in somebody. And I am going to ask Dr. Condon if she believes, based on this heart rate trend, if this is an automatic arrhythmia that we're looking at, where the heart rate gets up to like the 230s, or is this more likely a reentrant arrhythmia based on this heart rate trend from the telemetry?
So it looks like it gets there pretty quickly. And it's not in like the 200s. I forget if that's automatic or reentrant. I know either automatic or reentrant has like no warming up, cooling down, and it doesn't get up to like the 200s. I just forget
Well,
what.
okay, so the heart rate, you're right, they are distinguished by how rapidly they can onset. So automatic arrhythmias tend to have a slower onset, and that would be more consistent with this tracing, where you're sort of over a period of about 30 to 50 minutes, you're going from rates in the maybe in the 170s to rates in the 230s. The actual heart rate itself is helpful, but 230 or 240, as this tracing seems to reach to, would be a heart rate that could sort of touch into the reentrant rhythm rate, but also could be in the automatic. So it's a little, the heart rate isn't as helpful in this particular case. But generally, if we were looking at somebody who had a reentrant arrhythmia, the line would go straight up like this, not sort of this sort of general slow trend upward over a period of time. So this is more consistent with an automatic arrhythmia. And this is in fact the tracing of that patient. And what we see here is we don't obviously see P waves before each of the QRSs. I apologize for the poor quality of this tracing, but this is, here's one P wave. This is an example of junctional ectopic tachycardia in somebody. And in the coming weeks, we'll go over how to assess that and also how to treat that. But again, this is a nice example of how looking at the telemetry can be very helpful in making a diagnosis even before we look at the surface electrocardiogram. So both are very helpful in diagnosing. And I think with that, we're going to stop a little early today. Thanks for joining, and I'll see you in conference in a few minutes. I hope everybody has a great day today.
Thank you.
Thank you.